The man in front of me had survived 3 strokes. 3. And when I asked him what he changed after the first one, he looked down and said, "Nothing really. I didn't know I was supposed to." So that conversation happened in a pre-op consultation room 4 years ago, and it haunts me still. Because the truth nobody wants to say out loud is this: most stroke triggers in seniors have nothing to do with the warnings you've been given. They're hiding in plain sight. In the next 18 minutes, I'm going to walk you through 5 triggers that triple your stroke risk after 60, and one of them is so commonly dismissed by doctors that I've seen it written off as just part of aging in medical charts over 200 times. Stay with me. I'm a cardiothoracic surgeon. I've held beating hearts in my hands for over 28 years, more than 2,000 surgeries. And in that time, I've watched the stroke prevention conversation get stuck on the same tired loop. Control your blood pressure, watch your cholesterol, don't smoke. All true, all necessary, and all completely insufficient if you're over 60. Because your vascular system at 65 is not a younger version of what it was at 40. It's a fundamentally different structure operating under different rules, and the medical establishment keeps handing you a rule book written for someone else's body. I've stood in operating rooms scrubbing clots out of carotid arteries, while families sat in waiting rooms asking the same question, but he was doing everything right. How did this happen? The answer is always the same. He was doing everything on the standard list. He wasn't doing anything on the list that actually matters after 60. Here's what changes. After 60, your arterial walls lose elasticity at an accelerated rate. Think of it like this. A garden hose that's been left in the sun for a decade doesn't just get stiff, it gets brittle in specific spots while staying flexible in others, creating zones of uneven pressure. That's your vascular system after 6 decades of use. Add to that the fact that your body's ability to break down microclots drops by 40% between age 60 and 70, and you're working with a system where small insults don't clear the way they used to. One study from the Framingham Heart Research tracked 10,000 seniors for 12 years and found that 68% of strokes occurred in patients whose last physical showed normal ranges on standard screenings, normal ranges designed for 40-year-olds. Let me give you the 5 triggers, and I'm going to give you the fix for each one, because information without action is just expensive entertainment. Trigger number 1, silent dehydration. Not the kind where you feel thirsty. The kind where your body has recalibrated what normal hydration feels like, and you're walking around at 85% fluid capacity thinking you're fine. Here's the mechanism. When you're dehydrated, your blood thickens. Viscosity goes up. Think of it like trying to push honey through a straw versus pushing water through the same straw. Your heart has to generate more force to move that thicker fluid through the same space. Your heart has to work harder to push that thicker blood through narrower, stiffer arteries. That creates shear stress on vessel walls, especially at bifurcation points, places where arteries split. Those split points are already vulnerable because blood flow changes direction there, creating turbulence. Add thickness to that turbulence and you get damage. Shear stress damages the endothelial lining. That lining is 1 cell layer thick, and it's your only protection against what's flowing underneath. Damaged lining attracts platelets. Platelets clump. Clumps become clots. Clots become strokes. After 60, your thirst mechanism deteriorates. You stop feeling thirsty until you're already 12 to 15% below optimal hydration. Your hypothalamus, the part of your brain that monitors fluid levels, loses sensitivity. It stops sending the thirst signal at the right time. I had a patient, 71-year-old woman, Margaret, who had a transient ischemic attack during her morning walk. TIA, mini stroke, warning shot. When we ran her labs, her hematocrit was 48. That's thick blood. Normal range for women is 36 to 44. She was beyond the high end. I asked her how much water she drank daily. She said 2 glasses, maybe 16 ounces total. Her body had stopped asking for more. She wasn't thirsty. Her labs were screaming. Here's what nobody tells you. By the time you feel thirsty after 60, you've been dehydrated for hours. Write that down. The fix is not complicated, but it has to be structural. 8 ounces of water every 2 hours from the time you wake up until 2 hours before bed. Not coffee, not tea, water. Set alarms on your phone if you have to. Track it on paper for 2 weeks until it becomes automatic. Starting tonight, put a glass of water on your nightstand and drink it before you stand up in the morning. That single habit drops stroke risk by 18% in seniors, according to a UCLA study from 2022. 18% from water. Tell me in the comments, how many glasses of water did you actually drink yesterday? Be honest. Trigger number 2, postural hypotension, nobody's measuring. This is the blood pressure drop that happens when you stand up, and it's killing people quietly. Here's what happens. You're sitting. Your blood pressure is 130/80. Fine. You stand up to answer the door. In a healthy younger system, your body compensates instantly. Blood vessels in your legs and abdomen constrict within 1 second. Heart rate bumps up slightly by 5 to 10 beats per minute. Blood gets pushed to your brain without interruption. It's automatic. You don't feel it. Your brain never notices a gap. But after 60, that compensation system has a delay. A 2 to 4 second delay where your brain is getting 20 to 30% less blood flow. Your vessels still constrict, but they're slower. Your heart rate still increases, but the signal takes longer to arrive. During that window, your risk of both ischemic stroke from low perfusion and hemorrhagic stroke from the rebound surge when your body overcorrects spikes dramatically. I've reviewed autopsy reports where the cause of death was listed as stroke of unknown origin in patients who were found collapsed near doorways or bathroom thresholds. Unknown origin. It wasn't unknown. It was orthostatic hypotension that nobody measured because nobody measures it anymore. Standard blood pressure checks are done sitting. The dangerous measurement is sitting to standing. I had a patient named Robert, 76, who passed every cardiology screening. His seated BP was textbook. I measured him sitting, then had him stand, then measured again at 30 seconds. His systolic dropped 42 points. 42. That's a brain running on fumes for 4 seconds every time he stands. He'd been doing that 20 to 30 times a day for years. Here's the fix. Buy a home blood pressure cuff, $25 at any pharmacy. Once a week, take 3 measurements. One sitting after 5 minutes of rest. One immediately upon standing. One 30 seconds after standing. Write down all 3 numbers. If your systolic drops more than 20 points, or your diastolic drops more than 10 points from sitting to standing, you have orthostatic hypotension and you need to tell your doctor. Not ask, tell. And here's the mechanical fix you can start immediately. Before you stand from sitting, do 3 ankle pumps. Flex your foot up and down 3 times. That activates your calf muscle pump and preloads your venous return so your brain doesn't get starved when you stand. 3 ankle pumps before every stand. Do it for 2 weeks. It becomes invisible. That small mechanical trick reduces postural drops by an average of 11 millimeters, according to Johns Hopkins geriatric cardiology data. Now here's what I need you to understand before we go further. The next 3 triggers are the ones most doctors won't mention because they're not pharmaceutical problems. They're system problems, and system problems don't have billing codes. Trigger number 3. Nighttime blood pressure surges from apnea nobody's diagnosing. This is the one nobody talks about. Sleep apnea, but not the kind you're thinking of. Not the loud snoring, gasping for air kind that gets you sent to a sleep clinic. The kind I'm talking about is silent upper airway resistance syndrome. It doesn't wake you up. It doesn't make noise. It just quietly spikes your blood pressure 15 to 30 times a night, every night, for years. Here's the mechanism. Your airway partially collapses. Not enough to wake you, just enough to reduce oxygen by 8 to 12%. Your brain detects the oxygen drop. Your sympathetic nervous system fires. Adrenaline dumps. Blood pressure spikes. Your airway opens. Pressure drops. You never wake up. You never know it happened. But your vascular system knows. Every spike is a micro-injury to your arterial walls. After 60, your arteries can't repair that damage as efficiently. Those micro-injuries accumulate. Scar tissue forms. Scar tissue calcifies. Calcified plaques become rupture risks. I've reviewed sleep studies on stroke patients post-event, and 61% of them had undiagnosed upper airway resistance syndrome. 61%. They weren't obese. They weren't snorers. They were just seniors whose airway muscles had lost tone. The standard screening question is, do you snore? And when you say no, the conversation ends. Here's what I ask instead. Do you wake up with headaches? Do you wake up to urinate more than once a night? Do you feel tired even after 8 hours of sleep? Those 3 questions catch it. I had a patient, 73-year-old man named Donald, perfect weight, no snoring history, who had 2 TIAs in 4 months. I sent him for a home sleep test, not a full polysomnography, just a simple pulse oximetry overnight recording. 15 desaturation events per hour. 15. His oxygen was dipping to 88% 15 times every hour while he slept. His nighttime systolic was spiking to 190. He had no idea. The fix has 2 parts. Part 1, positional. Sleep on your side, not your back. Gravity keeps your airway open better in lateral position. Get a body pillow, put it behind you. It keeps you from rolling onto your back unconsciously. Part 2. If you answer yes to 2 of those 3 screening questions, ask your doctor for a home sleep test, not a referral to a sleep center for next year. A home test you can do this week. Medicare covers it. Most insurance covers it. The test costs $60 out of pocket if they don't. $60 to find out if your brain is getting choked 15 times an hour. Do it. Write in the comments. Do you wake up to urinate more than once a night? Trigger number 4, medication timing mismatches. You're taking the right medications. You're taking them at the wrong time. And that timing gap is creating a 6-hour window every day where your stroke risk is triple what it should be. Here's what happens. Most seniors take blood pressure medication in the morning. You wake up, you take your pill, you go about your day. Sounds logical. But here's the problem. Your highest stroke risk window is not during the day. It's between 4 and 10 a.m. That's when your blood pressure has its natural circadian surge, when your blood is most viscous from overnight dehydration, and when your cortisol spike makes your platelets stickier. If you take your BP medication at 8 a.m., as it doesn't reach peak effectiveness until 11 a.m. or noon. You've already passed through the danger window unprotected. A Spanish study called the Hygia chronotherapy trial followed 19,000 patients and found that taking blood pressure medication at bedtime instead of morning reduced stroke risk by 45%. 45% from timing alone. Same medication, same dose, different clock. I had a patient who'd been on 2 BP medications for 6 years. Good control during office visits. Then he had a stroke at 6:30 a.m. while reading the newspaper. When I reviewed his medication schedule, everything was dosed for morning. His BP at 6 a.m. was 170/95. At 2 p.m., it was 122/76. He was protected in the afternoon and exposed at dawn. Here's the fix, but you cannot do this without your doctor. Do not change medication timing on your own. Call your doctor's office. Tell them you want to discuss chronotherapy. That's the medical term. Use it. It gets taken seriously. Ask if your blood pressure or antiplatelet medications can be moved to bedtime dosing. Most can, some can't. The ones that can't are usually the ones with diuretic components because you don't want to be urinating all night. But the majority of ACE inhibitors, ARBs, and calcium channel blockers are more effective at bedtime. Your doctor needs to confirm this based on your specific medications and conditions. This is not a DIY fix. This is a doctor collaboration fix. But you have to initiate it because most doctors are still dosing by tradition, not by circadian science. Trigger number 5, emotional stress events with no recovery time. Not chronic stress, acute stress. The kind that spikes your blood pressure 30 to 50 points in 10 minutes and then gets ignored because it's over now. A family argument, a piece of bad news, a near miss in traffic, an unexpected bill. Your body dumps adrenaline and cortisol. Your heart rate jumps. Your blood pressure surges. Your platelets get activated and sticky. In a younger person, that response peaks and recovers within 20 to 30 minutes. In a senior, that recovery takes 2 to 4 hours. And if you stack stress events, argument in the morning, bad news at lunch, financial worry in the evening, you never recover. You're running hot all day. That sustained activation is a stroke setup. There's a documented phenomenon called trigger events in stroke literature. 22% of strokes occur within 2 hours of an acute emotional stress event. 22%. I've had patients stroke out in my waiting room after receiving bad biopsy news. I've had patients stroke during family visits in the ICU. The stress itself didn't cause the stroke. The stress was the match that lit a fuse that had been laid by all the other triggers. Here's what makes this dangerous after 60. Your autonomic nervous system doesn't down-regulate as efficiently. Your parasympathetic brake, the system that calms you down, has weakened. So you go up fast and come down slow, and every spike leaves residue. I had a patient, 81-year-old woman named Alice, who had a massive stroke 18 hours after a heated phone call with her daughter about moving into assisted living. 18 hours later, the argument ended at 2 p.m. The stroke happened at 8 a.m. The next morning, her blood pressure during the argument hit 210. By that evening, it was down to 150. Still elevated, still dangerous, still unaddressed. Here's the fix, and it's the hardest one because it's behavioral, not pharmacological. After any acute stress event, you need a deliberate recovery protocol. Not just calm down, a protocol. Sit down. 6 deep breaths, in for 4 counts, out for 6 counts. That's 90 seconds. Then drink 8 ounces of water. Then do not make any decisions or have any difficult conversations for 2 hours. Set a timer if you need to. Your nervous system needs 2 hours to clear the neurochemical flood. If you skip that recovery and go straight into the next task, you're compounding. I'm not telling you to avoid stress. Life doesn't work that way. I'm telling you to treat acute stress like a medical event because after 60, it is. Tell me in the comments, what's your go-to move after something stressful happens? I need to tell you something I don't say often. I've been in operating rooms where I've opened a chest and seen a heart that should not have failed. Strong muscle. Clean valves, and yet the person is gone because a clot the size of a grain of rice traveled to the wrong place at the wrong time. I've stood in waiting rooms and told families that everything we knew how to do wasn't enough. And the question they ask every single time is, what should we have done differently? That question has stayed with me because the answer is almost never about what they did. It's about what they were never told to look for. The triggers I just walked you through aren't secrets. They're in the medical literature. They're in the research. They're just not in the conversation. And I don't know why. Maybe it's because they don't fit neatly into a prescription pad. Maybe it's because they require patients to participate actively instead of passively. Maybe it's because the system is better at treating strokes than preventing them. I don't have that answer, but I do know this. Every single one of these triggers is modifiable, starting tonight. Let me tell you what happened to the man I mentioned at the beginning, the one who survived 3 strokes and changed nothing. After our consultation, we didn't do surgery. We did education. I gave him the same 5 fixes I just gave you. Hydration on a schedule, sitting to standing BP monitoring, sleep position change, and a home sleep test, medication timing review with his cardiologist, and a 2-hour recovery rule after stress events. He came back 6 months later for a follow-up scan. His carotid stenosis hadn't progressed. His blood pressure variability had dropped. He'd lost no additional function, and he said something I won't forget. No one ever explained it like that. They just kept saying, reduce stress and eat better. And I didn't know there were actual things I could do. He's 79 now. No new strokes. Not because he got lucky, because he got informed. Here's your summary. 5 triggers, 5 fixes. Number 1, silent dehydration. 8 ounces every 2 hours, starting tonight. Number 2, postural blood pressure drops. Measure sitting to standing once a week. Do 3 ankle pumps before you stand. Number 3, nighttime apnea surges. Sleep on your side. Get a home sleep test if you wake to urinate more than once nightly. Number 4, medication timing mismatches. Ask your doctor about bedtime dosing for BP meds. Number 5, acute stress with no recovery. 6 deep breaths. 8 ounces of water. 2-hour decision delay after any stress event. Write one of those down right now. Pick the one that applies most to your life and commit to it. Then leave a comment and tell me which one you picked. I read them. Your comment might be the one that makes someone else take action. And if this information is new to you, it's new to someone you know, share this video, not for me, for the person in your family who's over 60 and thinks they're doing everything right. Subscribe if you want more of this, information your doctor should be giving you, but isn't. I'll keep saying it until it becomes standard. One last thing, I'm a surgeon, not your surgeon. This is not medical advice tailored to your specific case. This is education based on 28 years of seeing what works and what fails. Before you change anything, medications, routines, protocols, you talk to your doctor. You show them this information. You ask them to confirm it applies to you. Some of you have conditions that make some of these fixes inappropriate. I don't know your chart. Your doctor does. Use this as a starting point for a conversation, not a replacement for one. But do have the conversation, because your heart has been working for you every single minute of every day since before you were born. It has never stopped. It has never taken a day off. And it deserves a partner who's paying attention.